It usually happens without warning. A sudden, sharp pain shoots down the back of one leg, mapping a line of agony from the lower back all the way down to the foot. For some, it feels like a severe, persistent burning sensation. For others, it brings a heavy numbness or noticeable muscle weakness that becomes almost unbearable when sitting down for too long. Millions of people who experience this specific pattern of leg pain share a common assumption. They believe they have contracted a specific disease called sciatica, but they haven't. Sciatica is a symptom, a descriptive term for a collection of painful signals. It is not a clinical diagnosis. Treating that leg pain without identifying exactly what is irritating the nerve is like turning off a fire alarm without looking for the fire. True relief requires finding the hidden, underlying structural failure. The human lower body houses the sciatic nerve, the longest continuous nerve in our anatomy. It is woven together from 5 distinct nerve roots, exiting the lower spine from the 4th lumbar vertebra down to the 3rd sacral level. These roots merge and travel through the pelvis, deep into the buttocks, branching out continuously all the way down to the toes. This vast geographic journey sets up a clinical phenomenon known as radicular pain. This is a biological glitch where the brain misinterprets exactly where a danger signal is coming from. If a nerve root is physically compressed near the spine, the brain will project that burning sensation far down the nerve's path, triggering an alarm in the outer leg or the top of the foot. Because of this anatomical trickery, the source of a patient's agony is almost always hiding far above the spot where they actually feel the pain. So, what is actually doing the pinching? To find out, we have to look closely at the structures surrounding those lumbar nerve roots. This cross-section of a lumbar vertebra shows a herniated disc. In younger and middle-aged adults, this is the most frequent culprit, where the soft inner material of a spinal disc bulges outward and presses directly against a nearby nerve. That protruding material physically crushes the root, but it also leaks inflammatory proteins, chemically irritating the nerve and sending severe pain signals down the leg. In older demographics, the landscape of the spine changes as the wear and tear of degenerative disc disease sets in. As we can see in this animation of a narrowing spinal canal, conditions like lumbar spinal stenosis and bone spurs become the primary threats. Age-related degenerative changes create bony growths that crowd the nerve openings. They consume the negative space in the canal, leaving no room for the nerve roots to safely exit the spine. In other cases, a condition called spondylolisthesis occurs. This is a structural instability where an entire block of the vertebra slides forward, creating a scissor-like pinch on the trapped nerve. And occasionally, the spine isn't to blame at all. In a small percentage of cases, known as piriformis syndrome, the nerve becomes irritated much further down as it passes near or directly through the glute muscles. The resulting leg pain feels identical to the patient in every single one of these scenarios. Yet the internal mechanical failure causing it is drastically different every time. This is why an accurate diagnosis dictates the treatment plan. A generic physical stretch might soothe the tight piriformis muscle, but applying that same motion could severely aggravate a herniated disc. Healthcare providers trace the exact nerve root involved by conducting targeted clinical evaluations, utilizing reflex, sensory, and muscle strength testing to pinpoint the structural failure. The good news is that most cases do not require immediate surgical intervention. They improve dramatically through conservative, evidence-based management. First-line approaches prioritize patient education, targeted therapeutic exercise, and manual therapies designed around a specific, root-cause structural diagnosis. Advanced imaging, like an MRI or CT scan, is highly effective, but generally reserved for cases presenting severe, progressive neurological deficits. Accepting sciatica as a final answer leaves the true problem unsolved. Demanding a thorough evaluation to identify the specific underlying cause is the only reliable pathway back to pain-free health.